Welcome to Chapter 29, Disorders of the Pleura. We're going to talk about some different things that happen with the pleura, including pneumothorax, pleural effusion, and flail chest. So let's get into it. So some of the things that you'll be able to do by the time you're done with this chapter or video is describe normal function of the pleural space in healthy kiddos, list the causes of pneumothorax in babies and in small children, recognize the causes of pleural effusions and empyema in children of all ages, as well as discuss how we manage these abnormal air and fluid in the pleural space in children. Hey everybody, so we're talking about the pleura today. As you know, the pleural space is not really a space at all. It is simply a potential space. It surrounds the outer surface of the lungs and the mediastinum, as well as the inner surface of the chest wall, and even covers the diaphragm. It is a sliding surface with just a tiny amount of fluid, about 1 to 5 mils of serous fluid that are in this potential space. The pleural membranes are super thin and permeable. The adult makes an estimated 5 to 10 liters of fluid per day that cross from the parietal pleura to the visceral pleura. Fluid production capacity is generally about 100 mils per hour. However, in the adult, we can absorb 3 times that, about 300 mils per hour. And this is how we keep just about 1 mil to 5 mils of normal fluid in the pleura at any given time. But what happens when things don't go right? So let's take a deeper look into the parietal and visceral pleura. As you can see, and I'm going to highlight this with a pointer, with a laser pointer. Here are the lungs, and surrounding the lungs are the 2 pleura. In the middle of the 2 pleura is the parietal pleural cavity. So the visceral pleura actually covers the surface of the lung itself, hence the name visceral, and the parietal pleura covers the diaphragm, the outer wall, the chest cavity wall. So again, it covers diaphragm, mediastinum, and the chest wall. Visceral pleura is just what it sounds like. It covers the viscera of the lung, or the surface of the lung, including all of the fissures. Talking about the fluid in the pleural space, remember that there are a bunch of different things that determine how fluid crosses the pleural membrane. So part of this is Starling's law of capillary exchange, including the standard physiologic or body parameters of hydrostatic pressure. That's water pressure, folks. Capillary permeability, are the capillaries letting fluid in and out? The water pressure, oncotic pressure itself, and lymphatic drainage, in addition to the negative interpleural pressure of the lungs. Remember that in the pleural pressure is always negative. And there is for every 100 mils, we have more that are made we have more fluid that leaves the lungs. So how does all this work? The intracapillary hydrostatic pressures tend to drive fluid out of the capillaries, and the pericapillary hydrostatic, so intra and pericapillary hydrostatic pressures tend to hold this off, keep this from happening. They counterbalance the force. The plasma oncotic pressure exerts a force also to retain fluid within the capillaries, and the pericapillary colloid oncotic pressure, boy, that's a mouthful, that tends to favor fluid movement out of the capillaries. Any change in balances of these forces will determine how much fluid stays in the pleural space. So how much is left in there. So some of the things that can happen, you can have increased capillary permeability. This happens in acute respiratory distress syndrome. You can have decreased intravascular colloid oncotic pressure. That's when there's not enough albumin in the blood, serum albumin in the blood, that protein part of the blood. And then there's also increased pulmonary venous pressure. That happens in heart failure, and heart failure can happen in kids. So all of these things are common, and they all contribute to the accumulation of fluid in the pleural space. It's really common to have a pleural effusion or fluid in the pleural space in heart failure. If the lymphatics, if that drainage is messed up for one reason or another, then fluid can also accumulate in the pleural space. There are a bunch of disorders that can also happen and retain fluid, including inflammation, infection, obstruction, and injury. We're going to look at some of the different pleural disorders by how they present clinically. So let's get into that. Let's talk about pleural effusions first. That is fluid in the pleural space. What does it look like clinically? Well, there will be an area of decreased intensity in breath sounds, so they're really hard to hear when you're listening. There may be a dullness in your percussion because you're percussing on an area with water, but that can be hard to determine. Generally, when I'm working clinically, when I listen to someone that has a pleural effusion, it's really hard to hear any breath sounds at all in the area. The patient usually is in respiratory distress. If it's a bigger accumulation, more than 100 mils, they can have chest pain and chest wall tenderness, difficulty breathing, and pain with coughing or deep breathing. How do we diagnose this? With a chest x-ray, but not just any chest x-ray. We want both an anterior posterior or posterior anterior, so a full-on frontal chest x-ray, as well as a lateral decubitus, which means it's a side line and they're lying with the bad side down. That is going to tell us where that fluid is. So ultrasound examination can also be used, as can CT. And those can be more sensitive when you have a really, really small accumulation of pleural fluid. But for those bigger ones, we're going to want a chest x-ray. And that's your gold standard go-to, is a chest x-ray, both an upright and a lateral decubitus. All right, you guys, so let's get into some common causes. Pleural effusions are generally put into two broad categories. They are either a exudative or a transudative, if you remember from disease class. In transudative, the most common cause of a transudative pleural effusion is CHF. Children can have CHF. So that is the most common cause of a transudative pleural effusion. However, the most common type of pleural effusion in pediatrics is actually an exudative pleural effusion, a parapneumonic effusion. This is what happens when there is accumulation of pleural fluid and the underlying cause is a pneumonia, typically a bacterial pneumonia, though parapneumonic pleural effusion can be a result of a viral, fungal, or even a parasitic infection. Including, it can also be caused in some countries, not as common here, tuberculosis as well. So those are some of that is the parapneumonic is the most common cause, usually by a bacterial infection. Now, a parapneumonic pleural effusion can also be called an empyema if the pneumonia extends all the way into the pleural space, not just in the lung, but also all the way into the pleural space. So if that is the case, then the effusion, if that infection goes all the way through from lung tissue into pleural space, then it is called an empyema. An empyema is considered positive if there is pus in the pleural space, and we can do that by culturing the pleural fluid. We can do a gram stain and CNS as well as a culture and sensitivity. How do we, now that you know some of the main causes, and make sure you look at box 29.2 and box 29.3 because it goes over all of transudative and exudative causes. But how do we treat this? Well, we treat it by doing a thoracentesis. That is placing a needle into the pleural space and withdrawing pleural fluid. Remember that we find this usually on chest x-ray, but we can also find it using ultrasound and CT as well, especially in the case of very small pleural effusions. In older adult cooperative children, in older, more cooperative children, a thoracentesis is usually the first thing that the clinical team will do to drain the fluid. This consists of putting a needle into that pleural space, withdrawing pleural fluid. And in many children's hospitals, the pleural drainage is increasingly done in interventional radiology with ultrasound guidance so that they make sure that they're getting into the right spot. Often a consideration for chest tube placement is based on the suspicion so they may or may not place a chest tube low in the chest with a pleural effusion, but if they think that this is due to a chronic disease process or an infection where the fluid is going to be thick and sticky like an empyema, they may place a chest tube. We can also, pleural fluid can be removed by a VATS procedure. This is video-assisted chest surgery, video-assisted thoracospic surgery, or a video-assisted chest surgery. The patient is, this is done in the surgical suite and under anesthesia with a special scope to remove the fluid. So what are some of what can go wrong? Complications include pneumothorax, hemorrhage, and infection. And in fact, we're going to talk about pneumothorax next, but those are just a few of the complications that can happen. And if you're following along with your book, there is a excellent picture of a 7-year-old with a large pleural effusion on the right. This is figure 29-1. The whole bottom third of the right hemithorax is white, and there is a meniscus sign. It's kind of rounded like water in a glass, but in this case it's in the lung, and there are air bronchograms as well in that right lower lobe. This is a parapneumonic effusion that is pictured, and it was an empyema caused by streptococcal pneumonia. So make sure you take a look on page 481 of your book in that in that upper corner to look at that picture. All right, so we're going to talk about pneumothorax next. Pneumothorax is air in the pleural space. Pneumothorax can be considered spontaneous if there was no trauma or procedure that happened before the pneumothorax occurred. So it means it just kind of out of the blue happens. Generally, this is in tall, thin young men that grow very quickly. They can have spontaneous pneumothorax that can happen. Common causes of pneumothorax in neonates include respiratory distress syndrome, also called hyaline membrane disease, meconium aspiration, barotrauma. They can have spontaneous pneumothorax. The first breath of life, if it's big enough and tough, hard enough, with enough pressure, can also cause a pneumothorax in a neonate. Or they can have some kind of congenital anomaly, including a congenital diaphragmatic hernia. Those are just a few of the causes in newborn babies. Some of the causes in older kids are chronic obstructive lung disease like asthma or cystic fibrosis, bronchopulmonary dysplasia, trauma, surgery. Trauma is pretty common in teens. There are knifings and unfortunately gunshot wounds, as well as you can have spontaneous pneumothorax in those young, thin men, also getting hit in the chest by a ball, or one that we create when we do surgery of some kind on the chest. That would be termed iatrogenic. It means that we created the pneumothorax. So how do you diagnose this? On examination, breath sounds may be decreased on the affected side. However, if you percuss it, it will be hyperresonant or tympanic, very high-pitched if you tap, like tapping on a drum. If it is a tension pneumothorax, which is life-threatening, just don't forget about that. There may be mediastinal or tracheal shift to the opposite side from the side that's affected where the pneumothorax is. Patient with a tension pneumothorax is generally cyanotic with severe respiratory distress, and there may be subcutaneous emphysema, which is a snap, crackle, pop, little pockets of air under the skin. On chest x-ray, lung markings are lost. You can't, it's very, very black. You cannot see any lung markings. and you can usually trace the line of the squished lung on the side where the pneumo is. Treatment is dependent on the clinical presentation of the kiddo. Are they, and whether or not there's a tension pneumothorax, are they stable or unstable? So also the size of the pneumothorax, as well as what is the underlying disease in the lung. For small spontaneous pneumothoraxes where the patient doesn't have any symptoms and they're stable, we can give 100% oxygen and monitor and do serial chest x-rays to make sure it's resolving. If it is a larger pneumo or the patient is unstable, or if they have a tension pneumothorax, the treatment of choice is a chest tube. So let's talk about chest tubes and chest tube drainage. The placement of a tube in the pleural space to drain either air, fluid, blood, or both out of the pleural space is called thoracostomy drainage. It is indicated anytime the patient has had open heart surgery, had a chest surgery for any reason, like a lung transplant, or if they've had a trauma and the surgeons have actually placed drains for various reasons, including empyema or trauma. An unstable patient, again in respiratory distress due to a tension pneumothorax, can be needle decompressed, but then needs to have a chest tube placed. Insertion outside of the operating room is generally done in the PICU or other intensive care unit, or in a specialized treatment area, because it's very serious and there is risks of complication. Sedation or anesthesia is usually needed for a pediatric patient, so a person skilled like an anesthesiologist is usually needed for the procedure, as well as a pediatric intensivist to actually place the chest tube. Once the chest tube is in place, the end is connected to a drain collection chamber. The 3-bottle system for thoracostomy drainage includes a collection chamber that collects pleural fluid, blood, or pus, a water seal chamber to prevent flow of air back into the chest. Bubbles in the chamber indicate an air leak, and fluid in the chamber should fluctuate with each breath. And then a suction control chamber, and so that is usually determines the degree of suction to the system, usually about 20 centimeters of water for kiddos. There are bubbles in this chamber, and sometimes these chambers, the suction control chamber is set with a valve and is waterless. So it just depends on the type of chamber that they have for collection. So what about when you get air in the mediastinum? You can have a pneumomediastinum. This means that there's air that leaks around into the pericardium or into the mediastinum around the heart. You can see that in the picture here. You can see the edge of the heart, as well as it's a good x-ray level clavicles, but you can see the dark space around the heart, and there shouldn't be. Clinical signs are chest, back, or neck pain, and if it's a very large pneumomediastinum, they may be extremely short of breath. Diagnosis is with a chest x-ray as seen here, and intervention usually isn't needed. They usually need to treat the underlying cause of a pneumomediastinum. It's often caused by chest trauma, including endotracheal and esophageal procedures, mechanical ventilation with high pressures causing barotrauma, or thoracic surgery. It can also be the result of underlying pulmonary disease like asthma. In children, the pulmonary alveolus can rupture, and it can result in air moving along vascular sheaths and into the mediastinum. So this can be caused by violent coughing or lifting heavy objects. The most common causes, though, are in children of pneumomediastinum are asthma and infections. Treatment of the underlying disease in this case, like treating asthma, is key in helping to get this to resolve. So what about surgery? I've talked about different surgeries that can occur in the pleural space. Some of those surgeries usually have an open incision through the thorax via a thoracotomy or a median sternotomy, where they actually open the sternum, or a minimally invasive technique with the use of a thoracoscope. The scope allows the surgeon to insert a video camera into the pleural space and actually lets them look in real time at the surgical field, and this is called a VATS procedure, or a video-assisted thoracoscopic surgery. VATS are minimally invasive, and the major advantage is that they don't actually open more than a very small incision in the chest, and that means less post-operative pain and a much quicker recovery for the kiddo. Size limitations of the equipment may limit the usefulness of thoracoscopy in premature infants and neonates, so you don't usually see it in that set. However, there are more and more anesthesiologists and surgeons who routinely perform VATS in treatment of esophageal atresia, as well as tracheoesophageal fistula, congenital diaphragmatic hernias, pulmonary lobectomy for congenital pulmonary airway malformations, and ligation of a PDA with a video-assisted VATS procedure. General anesthesia and unilateral lung ventilation may be required for both open or a VATS procedure. Single lung ventilation can be accomplished by using a double lumen ET tube in bigger patients like teenagers, or by performing main stem intubation and blocking off the lung that they're working on. Most common indications for surgery in the pleural space in pediatrics include diagnosis and management of pleural disease, including recurrent pneumothorax and evacuations of empyemas. So going in, scooping out infection or empyema that they can't get to resolve any other way, as well as those tall, thin young men who pop pneumos over and over, and so we may have to do chemical pleurodesis with them, or even a VATS procedure. Chemical pleurodesis is sometimes attempted in kids with persistent or recurrent pneumothorax, though surgical intervention is preferred. Pleurodesis uses either a sterile tetracycline powder or a talc, sterile talcum powder, to produce the inflammation that will make the pleura stick together. It gets all irritated and inflamed, and then they stick together, but this really, really hurts. Pleurodesis is not pleasant, and they do need adequate pain meds when that happens. So it can be done. The use of either chemical or surgical pleurodesis can complicate or prohibit consideration of lung transplantation. So they have to be careful about who they do it on. All right, folks, some few last reminders. Management of disease in the pleural space in kiddos can be challenging. Every patient should have individualized multidisciplinary treatment and a good therapeutic plan with flexibility to change on the fly if needed. Depending on what works and doesn't work. They do a VATS procedure and they can't visualize enough. They're going to have to change on a dime and go to an open thoracotomy. So they need a team that can pivot quickly in these cases. They also need RTs that are familiar with kiddos, and you will be taking care of chest tubes and patients on ventilators in the PICU post-op. So something to keep in mind. Thank you very much. Have a good rest of your day. I hope this helped, and feel free to reach out to me via email if you have questions.